All right, so I'm going to tell you a story about a 67-year-old lady. She came to my office with a primary complaint of back pain and an inability to stand upright. Now, she was relatively active. She had to use a cane or a walker for long distances, but she was still getting around. She was doing everything she needed to do. She was going to the grocery store, even though it was pretty difficult. And things had been getting worse for her over the last couple years. This particular person had had a history of spine surgery in the past. Specifically, she had had 3 spine surgeries, 1 laminectomy and 2 fusions. The important thing about her is she didn't really have much leg pain. Everything was concentrated in the lower back and sort of radiated into the butt, but didn't really go past there. She wasn't having pain shooting down the legs. She wasn't having any numbness or tingling. Everything was very much in the lower back. The feeling also went completely away when she was lying down. So that gave me a hint that this was probably what I would call an alignment problem. The first thing I did when I saw her in the office, after getting the timeline of her complaints, after learning about the previous spine surgery she had, after making sure she didn't have any major lung or heart problems, is I did a physical exam. And on the exam, I saw that all her nerves were working fine. Her legs were strong, she didn't have any numbness or weakness, and she had normal reflexes. So the next thing I did was I got imaging. I got a full body x-ray so I could really see her entire body alignment. I got a CT scan so that I could look at the bones to see if the previous fusions had actually taken. And then finally I got an MRI so I could look at the nerves. Even though I wasn't suspicious that this was necessarily a stenosis problem, meaning I didn't really think it was a nerve compression problem, which is what stenosis means in some regard. I still had to get an MRI to make sure that there wasn't any nerve compression, especially if I was considering any surgery. So when I got the x-ray, here's what I found. I found that the bottom of her spine was fused too flat. And when we measured her out, we found that she was lacking the appropriate curvature in the bottom part of the spine, in the lumbar spine. In some patients, getting what's called a flat back can happen completely spontaneously. However, in a lot of patients, it happens because they had a previous spine surgery where they were fused too flat or fused more flat than would be ideal for that person to stand upright. That was the case with this patient. She had had previous spine surgeries years ago and she was fused a bit too flat. To stand in an upright position, most people need to have lordosis at the bottom part of the spine. And what lordosis means is it's just a backward curvature. When patients lose that backward curvature, it can force their body into sort of a forward-leaning position. As a result, the muscles in the back and actually in the pelvis and even in the legs have to work overtime so that that person can stand upright. This is very taxing because as throughout the course of the day, it becomes harder and harder. And this leads to pain and a lot of times a big sense of fatigue in the back. Here's what we found on the MRI. Looking at the MRI, this is a sideways view. So this is the front and this is the back. These are the bones, and then here are the nerves coming down. Now, I noticed that she had a little bit of pinching of the nerve roots, but it didn't really fit with her symptoms. Her symptoms were much more concentrated in the lower back, not so much in the legs. Usually when the nerve root compression is a problem, patients have leg pain. But for her, it was much more of a back pain issue, which made me think it was more related to the structural problem of her spine. We also got the CT scan. What the CT scan showed me was that all the bones were solidly fused together. So when the bones are all solidly fused together, as in her case, that makes your surgical options a bit more narrow. Specifically, when the bones are fused together, if we need to put them in a new position or give it more curvature, give it more lordosis, then that means we actually have to cut a wedge into the bones in order to restore that curvature. The surgery we discussed was something called a pedicle subtraction osteotomy. Now what this is when we cut a wedge in the spine. So we go into the previously fused area and we take out a bone called the pedicle, or that's really part of a bone. And by cutting that wedge, we're able to manipulate the spine to give it more curvature. Or the other thing I saw from the x-ray that's very important is I saw that she had some compression fractures in the upper lumbar spine. So I also sent this woman for a test to test for osteoporosis. We found out that she had osteoporosis. So therefore, before we could even consider surgery, there was a few things I needed her to do. The first thing we did was we sent her to get treatment for osteoporosis. Now this is essential because any times we're putting screws and rods in the spine, we need to make sure they have good bone to hold on to. The second thing I sent her for was physical therapy. Now, she had tried multiple rounds of physical therapy in the past. I mean, the fact that it didn't work is why we were considering surgery. But the reason I really wanted her to do physical therapy was to strengthen herself before surgery. The third thing that we had her do was do some kind of cardiovascular exercise about 20 minutes a day. So for her, a recumbent bike was the easiest thing for her to do. Some patients it's easier to swim, some patients are able to walk, but the point was I needed her to get her heart rate up for about 20 to 30 minutes a day to really make sure she was as strong as possible before the surgery. The last thing we had her do was make sure that all of her medical conditions were under control. Now, fortunately for her, she didn't really have too much going on from a health perspective. She had mild diabetes, which was controlled with metformin, so we made sure that her diabetes stayed well under control before doing any surgery. So once we made her the best version of herself that she could possibly be, we took her for surgery. After the surgery, she was in the hospital for about 4 days, and then she left and went home. She's about 6 months out now, and she's doing pretty well. I mean, you know, her back pain is very much improved, and she's no longer walking using any assistive device. So here are her x-rays that we just got from her 6-month visit. So here, this is looking at her from the front. You can see that we made sure that she was still well aligned when looking at her from the front. So we made sure that we didn't pitch her off to the side or create a scoliosis. You can also see that we used multiple rods. So a lot of times when we're doing these pedicle subtraction osteotomies, we use even more than 2 rods to give extra strength in the back. But this is actually the x-ray that tells the biggest story. So this is looking at her from the side. Now before, at the bottom of her spine, she only had about 6 degrees of backward curvature. Now she has 46 degrees, and this makes it much more easy for her to stand upright. It takes the pressure off all those muscles that were working overtime. So now she's able to walk without using a cane or a walker, and her back pain is much improved. She's still relatively early in the recovery process. 6 months, well, it seems like a long time. She's got a whole lot of life to live. So we'll see how she's doing over the next few years, but I expect her to have a good result.